This lecture will cover the lab math for the hematology department within the laboratory. Just as a reminder, hematology is the study of cells within the body. These cells will include the white blood cells, platelets, and red blood cells, which make up the largest quantity of cells within the circulation. Now, your red blood cells are responsible for carrying oxygen to and from the lungs, as well as going back and forth to the tissue to transport carbon dioxide from the tissue back to the lungs where it is later exhaled. And then oxygen, as you know, is carried by the hemoglobin molecules throughout the body. In addition to the cell count, a hemoglobin hematocrit are performed as part of the routine CBC. This is also known as an H&H. Hematocrit is the ratio of the blood cells in the total volume of plasma, and it's actually expressed as a percentage. So at this point, you don't really need to know the reference intervals for hemoglobin hematocrit or any of these analytes that we are discussing. And this is because that they can vary slightly from textbook to textbook, as well as from testing site to testing site. So for now, we're just focusing on the actual calculations. So there is a relationship between your H&H, your hemoglobin hematocrit values, that is very useful as a quality control type of tool, so that you can use this when you're assessing these values and determining whether or not your results are acceptable to report. The hematocrit is usually 3 times the hemoglobin plus or minus 3. So if the hematocrit is known, then you can, from that, determine an approximation of the hemoglobin and vice versa. So this is a very good rule to keep in mind when you're evaluating your printouts. If you have an abnormal hemoglobin hematocrit result, or even your red blood cell result, that can help you to kind of do a check to see if your results are valid. So you can also determine the rule of 3 by using 3 times RBC equals the hemoglobin plus or minus 3, and then 3 times your hemoglobin equals your hematocrit plus or minus 3. Now, not all textbooks or laboratories use this rule here for your red blood cells. That's red blood cells times 3 will equal your hemoglobin, but it is a good tool to kind of keep in mind. There are some exceptions where this rule of 3 for your red blood cells can be violated. But overall, it's a good tool to kind of assess your results. So here we have an example. A finger stick was performed on a young boy in a pediatrician's office. The hematocrit results were 45 and the hemoglobin was 11. Are these results consistent with the rule of 3? Well, what we would need to do is determine, is our hematocrit correct? So based off of these results, if we did 3 times our hemoglobin, that's going to give us a result of 33, which means that our hematocrit should be plus or minus 33, which is going to give us, it should be within 30 to 36. However, we're above that, so we know that this is not valid, that this rule has been violated. So from there, we would determine that we would need to investigate why this discrepancy has taken place. When the rule of 3 is not found, it may be an indicator that there's an error somewhere, or that there's some sort of abnormality within the size of the red blood cell or the amount of hemoglobin in the red blood cell. So the error that could take place could be an instrument malfunction of some sort. Maybe the patients were mixed up during testing or collection. Maybe there's a problem in reporting the correct result for some reason. Some sort of instrument error in transmitting those results, or it could be a problem with the patient's red blood cells. So the rule of 3 can be used as an estimate for your hemoglobin hematocrit values. If you figure out that something is off based off this rule, then your first flag should be that you're going to check and find out what is causing this violation. So this should be part of your quality checks when you're reviewing results for any patient, is to verify whether or not that rule of 3 has been violated. The size of the actual red blood cell itself is very important when we're looking at our slides and when the analyzer is assessing the red blood cell for its size, because we use the size to kind of help determine what the anemias are and how to treat them. So some anemias cause the red blood cells to be smaller than normal, while some of them can actually be a little bit larger than normal. So the relationship between the size, the hemoglobin content, the hematocrit was all mathematically determined around 1920. So there are three formulas that were described to help you with that red blood cell morphology and the classification of that morphology and being able to classify it into specific anemias. And you'll learn more about these anemias once you actually get into hematology. And so those values that are calculated are called the MCV, the mean corpuscular volume, the mean corpuscular hemoglobin, and the mean corpuscular hemoglobin concentration. And so that's the MCV, MCH, and MCHC. The MCV gives you the average volume or the size of the actual red blood cell in centiliters, and it is calculated by the following formula. It is your hematocrit times 10 divided by your red blood cell count. And your red blood cell count should be in 10 to the 12th per liter. Your normal range for MCV is 80 to 100 centiliters. So if you have an MCV that is lower than 80, now you do have some textbooks that will say about 75 to 100. But as a general rule, most laboratories do use about 80 to 100 for their MCV value. So MCV less than 80 is going to suggest that those red blood cells are smaller in size, whereas an MCV of greater than 100 is going to suggest that those red blood cells are larger. Now you can get some discrepancies here, because if you have a population that's mixed between normal and abnormal cells, or if you have a lot of smaller cells and larger cells, then it can kind of offset that value a little bit. So just because your MCV does fall in normal range does not mean that you do not have some abnormal cells, so you still have to train your eye to do that visual check when you're reviewing a differential on a slide. So here we have an example of our MCV. So if our hematocrit is 45 and our red blood cell count is 4.5, then we would do 45 times 10 divided by 4.5, which is going to give us an MCV of 100. The MCH represents the average amount of hemoglobin that's actually inside of that red cell. So this is going to kind of give you an indication if you see some that are really, really dark versus some that actually have that more classic, where it's kind of got that little bit of clearing of the white in the center, versus some that you just basically see that outside edge with a lot of the white in the center. And so when you're doing these calculations, it's only going to be significant to the nearest tenth, so you don't have to write out all those decimal points. And you calculate this by using your hemoglobin and your red blood cell count. So it will be your hemoglobin times 10 divided by your red blood cell count. So we have an example here where our hemoglobin concentration is 16 and our red blood cell count 5.6. So we plug that into our equation, 16 times 10 divided by our red blood cell count, 5.6, which gives us 160 over 5.6. And then we divide that out, we get 28.6 for our MCH. Your MCHC is the ratio of hemoglobin to the hematocrit. And so this is going to be represented in terms of grams per deciliter or grams per liter. And it's significant only to the nearest tenth. This represents the average hemoglobin content in the patient's red blood cell population. So this is going to give you an overall picture of how much hemoglobin content is in that patient's red blood cells. So this is the value that most places will use when they're evaluating their printout data. They're going to be looking at that MCHC to kind of give you a heads up of whether that's patient cells going to be hypochromic, normochromic, or hypo or hyperchromic. Your MCHC is calculated by using your hemoglobin times 100 divided by the hematocrit. Here we have an example where our hemoglobin is 10 with a hematocrit of 30. We plug those numbers in, so our hemoglobin of 10 times 100 divided by 30, and that will give us approximately 33 grams per deciliter for our MCHC. The RDW is the red blood cell distribution width, or the red cell distribution width, and it is a measurement of the degree of anisocytosis that's present in your patient sample. And so anisocytosis is a variation of the size of the red blood cell. So if you have large ones and small ones in there, then it's going to be a differentiation in size. And this is usually calculated by the automated analyzers, and it does that by taking the standard deviation of the MCV times 100 and dividing that by the mean MCV. Now, if you have a lot of nucleated red blood cells within your patient's sample, then when it's actually going through the machine thinks that those are white blood cells. So you will have to do a correction. If you have more than 5 nucleated red blood cells in your patient sample, you need to do the correction for that white blood cell count, because it's going to falsely elevate your white blood cell count. So nucleated red blood cells are immature red blood cells. They still have the nucleus present inside of them. They're normally found only in the bone marrow. Occasionally you may find 1 or 2 in a normal patient sample. If you get above 5, it's going to alter your count a little bit, so you need to do this calculation. You're going to see these if there's any sort of severe anemic stress or any reason for the body to be producing cells at an increased rate, and may spit those nucleated red blood cells out just a little bit sooner, just to get those in circulation. They're a normal finding within healthy newborns, and they usually disappear after a few days. And this is a good sign. You actually want to see nucleated red blood cells in newborns, because it indicates that they're able to make their own red blood cells and they're doing it adequately. They do contain the nucleus, and like I said, it will affect that instrument readout for your white blood cells. It does interfere with your white blood cells, because that nucleus is going through that aperture when it's trying to count white blood cells, because that nucleus is not going to lyse from that red blood cell. So in order to get a corrected count, if your nucleated red blood cell count is greater than 5 per 100 white blood cells, so when you're looking at it on a peripheral blood smear, then you need to do this calculation. So to do that, you will take your automated count times 100, and you will divide that by the number of nucleated red blood cells that you count plus 100. A lot of your analyzers today will actually do this calculation for you. It will put that corrected count on your printout, so you don't even have to do this anymore, but it is still possible that you may work at a facility that does not have an analyzer with this capability, so you may still need to do this calculation on your own. So here we have an example of doing a corrected white blood cell count. Also want to kind of point out here that when you indicate that a white blood cell is corrected, it will have a lowercase c at the beginning of it to indicate corrected white blood cell count. So in this particular example, it was a premature newborn that was born at 36 weeks gestation with a nucleated red blood cell count of 26 when they were doing the differential. So they did the differential, counted 100 cells, and while they were doing that count of the 100 white blood cells, they saw an additional 26 nucleated red blood cells. So if the baby's automated count is 25.7, we plug that into the equation. Our automated count, 27.5, times 100, and then we plug in our nucleated at 26 plus 100. Once we do that calculation and work that out, that gives us a corrected white blood cell count of 21.8. So as you can see, those nucleated red blood cells increase that count significantly. So it's very important that you do that count, because it could show or indicate a falsely elevated white blood cell count that's really not accurate. Now, while most of your white blood cell, red blood cell platelet counts are done through an automated analyzer, there was a point in time that they were performed on a Neubauer hemocytometer. We still use these for body fluid counts. Some places do use automation now for their body fluid counts, or there may be situations where they're really thick or need dilutions or something, small volume, or in various situations, or just that particular laboratory doesn't have any way to run it automated, then you still would have to revert back to using a hematometer. So we'll talk a little bit about the hematometer, the grid on it, how you use it, and exactly how you do those calculations. Now we will go over this more in depth once we actually get to our body fluids course. However, for now we're just going to kind of briefly go over how to do some of these calculations just so that you're aware when the time does come. So a hematometer, they used to be glass. There are plastic disposable ones now, but a lot of places do still have the glass ones that you reuse. So this whole piece here is glass, and then you have this tiny little cover slip that lays over top of it. Once you place that cover slip down, you have these little notches that you see this little arrow pointing to that you will use to put your fluid in, and it will do a capillary action to kind of draw that fluid into this chamber. And then what you see here, all of this is what we call like a moat. It's a little well around the side of this, so you can kind of see it here where you have this little area looking at it from the side where you've kind of got that little moat there for the excess to flow over. But you can also see, if you look real closely, right there in between that cover slip that lays over top of it, and then your actual counting chamber is going to be here in the center part. Here is where your counting portion of this is, where your grid is. But you can see a little bit of space in between that cover slip and your actual the actual chamber itself. So that space there is where your cells are going to sit. And so once you load it, you'll allow time for those cells to kind of settle down and come to all to the same plane, so that's easier to count, and then your excess is going to go over into the little moat area. But that depth in between the actual hematometer itself and the cover slip has a depth of 0.1 millimeters. So that's the depth of that sample that's actually in there. So each chamber contains an etched area within a grid that gives you a total of a 9 millimeters squared. So you have 9 of these really large squares. So when we talk about a large square, we're talking about this whole part here. So you have 9 of those large squares, and then within those you have additional smaller squares. Now this grid here doesn't actually give you a valid representation of what these grids look like, but you will get a better visual of this once you actually get into your, like I said, your body fluids class. But these grids here are actually broken down even smaller within each of these. It's a lot smaller than what you see here as far as what's actually on this. So there's more to these. Anyway, so each chamber has a total of 9 of those large squares. They're identical on each side. So when you look at this larger hematometer here, you have the grids here on one side, and then you have the grids here on the other side. So when you're loading this, you're actually looking for the tip of this little etched area. And once you find that, your grid is just right up from it. You will count each chamber or each side of these chambers. So you'll count the one side, the 9 grids, and then you'll switch over to the other side and count the other 9 grids, or whatever you're supposed to count based off of what you're looking for, whether it's white blood cells, platelets. But you'll count one side, you'll count the other side, and they should be within a 10% agreement. If you need to do a dilution, you'll also factor that in. And you also had to factor in the depth of that chamber. So as I mentioned, the large square is divided into 16 smaller squares. That center square has 25 small squares within each of those, within that large block, and each of the 25 small squares is further divided into 16 smaller squares, and you use that for your white blood cell platelet counting. White blood cells are counted in the 4 outside corners, so that's that 1, 3, 7, and 9, your outside corners. Platelets are counted, as well as red blood cells are counted in that large central square, and then that one's further divided down into smaller squares. So each square is a 1 millimeter square. Now this is important when we're doing these calculations. When performing white blood cell counts on a hematometer, there may be situations where you would need to do a dilution. So let's just say you had a joint fluid, there's an infection, there's a lot of white blood cells, and if you load that on a hematometer, they're just kind of overlapped over each other and you can't really count them. So you need to do a dilution just so that you're able to visualize and count those white blood cells individually and not grouped together. There may be situations too where maybe there's a lot of red blood cells. Let's just say again a joint fluid, traumatic tap, there's a lot of bleeding and red cells in there. So you cannot see those white blood cells because there's so many red blood cells. So you would actually do your dilution with something like acetic acid or hypochloric acid to actually break open those red blood cells and make those white blood cells be visible. So one of the main things that we need to know when we're doing our calculations, once we've done our counts and we've got our numbers and we're plugging those in, is that we need to know what the volume of that large square is. So for white blood cells, reminder, we count those 4 outside corners, and then we'll plug that into our equation. If there's a dilution, you'll plug that dilution in as well. But in order to plug into our equation, we need to know the volume of each of those squares that we are counting. So the volume of the large square itself is going to equal 0.1 millimeters to the third. And how we get that is the fact that the area times the depth is going to give us this. So the area of the square itself is 1 millimeter square, and then the depth from that chamber to that cover slip is 0.1. And so once we plug that in, that gives us the 0.1 millimeters to the third. Now the formula that we're going to use that's given to us by our textbook is listed here. Now the site that you go to could have some variations in how they do some of these formulas, so you will need to follow what your site says as far as what particular areas that they want you to count. For instance, some places may have you count just the outside corners, some places may have you count the outside corners and the center, and they will also give you the equation that they're going to use based off of what their requirements are as far as what they expect you to count. But for now, our calculations are going to be based off of the number of cells counted times the depth factor times the dilution factor divided by the total area counted, and we're going to report that in millimeters to the third. So our area counted is those large squares that we're going to count, those outside corners. That's the area counted. The depth factor is the reciprocal of the depth, so that is actually calculated with 1 divided by 1/10, and which is going to give you a value of 10. And then our dilution factor is going to be the reciprocal of the dilution that's actually performed. In this particular example, white blood cell count was performed on a sample that was abnormally decreased or below the linearity of what the cell counter could actually perform. A 1 to 10 dilution was performed. All white blood cells in each of the 4 corners of the grids of the hematometer were counted for a total of 75 white blood cells. What is the total white blood cell count? So we counted the 4 corners of both sides of the grid, so that's a total of 8. Dilution factor of 10, so a 1 to 10 dilution, or a 1 part sample to a 10 parts total, so it was 1 part sample, 9 parts diluent to give you a 1 to 10 dilution, so you use that 10 as your actual dilution factor, and then you plug that into the equation. So the total number of cells that were counted, and remember we got our depth factor of 10 times our dilution factor of 10, and then we divide that by the total, or the area that we counted. Remember, one square is 1 millimeter squared, so with 8 of those, that would be 8. Once you work that out, that will give you a total count of 938 millimeters to the third. And if you were going to write that out, you could reduce that down to 0.938 times 10 to the ninth. And that's just basically going to be based off of what your site says as far as your reporting parameters, microliters versus liters. So you will have to do based off of what your site says. Now, if you're lucky enough to be at a site that still uses the hemocytometers and does manual white blood cell counts or does manual body fluid counts, you can use a standard dilution of a standard dilution of 20. So it would be 1 part sample to 19 parts of your diluent. You could use the Unipets for this. It's a little dilution system where you can order the pre-diluted chambers and load your blood sample in it, mix it. It's a pipette all in one. And so if you do that, if you use the dilution factor of 20 for your calculation, then if you were to work out all those numbers, then it would actually give you a factor of 50. So it kind of simplifies your actual equation to do quicker calculations when you use the hemocytometer. So this allows you to multiply the total number of cells that you count in all four corners and multiply that by 50 to give you your total white blood cell count. Now again, you have to have a dilution factor of 20 in order for this to work, as well as counting the four corners, the large four corners of your hemocytometer. So here we have an example where the dilution was done for this particular sample. Dilution factor of 20. There were 140 white blood cells counted in the four large squares, corner squares. And then, so if you multiply that by 50, that's going to give you 7,000 per millimeters to the third. And then, of course, you can simplify that depending on how your site is going to report out those values. So next we're going to talk about platelet counting by the hemocytometer. So platelets, just as a reminder, are fragments of cells that are found in the bone marrow, those megakaryocytes, and so platelets are actually broken off fragments of those cells, and they will actually start the coagulation process. So for platelets, we count all 25 squares in the center of the hemocytometer, so that one center square in the hemocytometer, and we're going to count all of the smaller 25 squares that's within that larger square. This gives us a total area of 1 millimeter squared. And then from there, to do your dilution, you would use a 100 dilution factor. And again, you could use Unipets for this as well to finish out those calculations and do that dilution. So just like with our white blood cells where we use that dilution factor of 20, if you use the dilution of 100 for your white blood cells, then we can get that factor. Your white blood cells, it was 50. With our platelets, it's 1,000. Now again, this is only if you do the 100, and of course you count that center square. Now within that center square, you've got the 25 smaller squares that are broken down into 16 smaller squares, which is going to give you a total of 400 really teeny tiny little squares within that large center square. So as long as you do that 100 dilution or times 100 dilution, and you count all of those tiny squares within that one large center square, then you can just multiply your total count by 1,000. So if our platelet count was 150 times 1,000, that's going to give us 150,000 millimeters to the third. And then of course you can simplify that out if needed. So while most places aren't going to use a hemocytometer to actually do your red blood cell, white blood cell, platelet counts, we do use them for our body fluid counts. And so this is going to be things like spinal fluid, pleural fluid, peritoneal fluid, joint fluid, semen analysis. And when we do these counts, when when those fluids are collected, they're placed into sterile tubes, and then those tubes have a number on them, 1, 2, 3, and sometimes 4, just depending on the site and what type of kit that they use. But tube 1 is going to be your chemistry testing, so this is going to be for things like glucose, protein, any kind of serology testing that may need to be done on that tube. Tube 2 will be microbiology, and then tube 3 will be hematology. Now the purpose behind doing tube 2 for microbiology will be that you've actually got that puncture, initial puncture out of the way. Your site's been cleaned, you got the initial puncture out of the way. That goes in tube 1, so that when you're ready to get to tube 2, hopefully any kind of contaminant that possibly could have been on the skin has gone, so it's not going to interfere with tube 2. And then of course with tube 3, if there was any sort of traumatic stick, then those red blood cells could be flushed away. So you could see some variation in color from tube 1 to tube 3 just based off of the stick. So if you compare those 3 tubes together and you see that the red cells are visible in tube 1 but not in tube 3, then that gives you indication that it was some sort of like traumatic stick, versus if you have red blood cell distribution throughout all 3 tubes, then you know that it's a legitimate bleed. So in order to get the most accurate results, you do want to perform those cell counts within an hour. So this is usually going to be considered a stat test whenever it comes to the lab, any sort of body fluid, especially spinal fluid. Because typically with spinal fluid you're looking for the potential for meningitis, so you definitely want to address that tube quickly to make sure that you can start treatment quickly. And the reason why you want to do that testing so quickly is because those cells will start to deteriorate the longer they sit in that fluid and just get exposed to the elements. So you do want to, that is kind of considered a stat or ASAP type test. So some hematology analyzers can do cell counts on spinal fluid and other body fluids. Some may not have the capabilities of doing those body counts, or it may only have the capability to do it on certain fluids. So there are going to be situations where you probably will still have to resort to doing a hemocytometer. Cell counts for synovial, pleural, pericardial, peritoneal fluids are going to be collected in an actual blood test tube, not just like where your CSF is in a tube that has no additive in it. Your other fluids will be in tubes that have additives in it, heparinized or EDTA type tubes, and this is to keep that fluid from actually clotting. So if that fluid clots and all those cells move into that clot, then you're not able to visualize them when you're actually doing that count. There may be situations where you actually have to do a dilution on a fluid. So if the fluid comes to you and it's clear, you probably aren't going to need to do a dilution. However, if you can see that visually it's got a little bit of a cloudiness to it, then you will need to do that dilution. There are also different kinds of dyes that you can add to the fluid just to kind of help you visualize the nucleus within those cells. Some places do not have the stain to actually do the dye, or the stain you may can find it like within micro or your hematology kit for your right stain. However, I would recommend that you get used to looking at these cells without dye, just like you would with your analysis, because you may be at a facility that does not have access to this dye. If you need to do the dilution on the sample, you just need to remember to make sure that you factor that dilution factor in when you're doing your actual calculations. The squares that you count, the number of squares that you count, is going to be based off of the particular fluid and what your policy is for your particular laboratory. Now, as I previously mentioned, your site will have its own set of calculations of what it expects you to do. However, here, the example that's provided in the book, there's a chart that kind of lists some various methods of dilution. So with this particular patient, they had a pleural fluid that was cloudy because the patient had pneumonia, which getting a cloudy fluid from a patient that has some sort of infection is pretty consistent with that diagnosis. That cloudiness is going to come from those white blood cells that are in that specimen due to that inflammation and that inflammatory process. So for this particular sample, method C was used. One side of the chamber was counted for 40 white blood cells, the other side for 48. And so we've got to do the calculations to determine what that actual white blood cell count is. So each of those chambers, each side was counted, and we want to make sure that those results are within 10%. If they're not within 10%, then you need to repeat that. It could be that you just didn't get a good load on that chamber, or maybe you had an air bubble in it. If you have a cover slip, maybe you bumped that cover slip, or maybe you took too long and it started to dry out. So if your results don't match, you need to repeat it. If they do match within 10%, then you're going to get the average, and then you're going to multiply that based off of whatever your site-specific equation is. So for this example, we got to refer to our chart in our book. And our chart in our book tells us that with this particular method, if we used method C, and we counted the 4 corners on each side, so those 4 outside corners. So when we look in our table, if we counted the 4 corners, then method C would mean that we'd need to multiply that by 505. So if we got our average of 44 based off of those 2 sides, we multiply that by 505, and then that's going to give us our total white blood cell count. There are some situations where CSF can be contaminated due to a traumatic tap, because there are, capillaries that have to be crossed through whenever you're performing that puncture within the spinal column. So you could have some excess white blood cells and red blood cells. So there are some laboratories that will actually do a calculation for this. It's not something that I've ever done. It's not something I'm very familiar with doing. However, do keep in mind that it could be a possibility that you would have to do a corrected count based off of there being some contamination from that bloody stick from that CSF collection. And so if you do that, I'm sure your site's going to be familiar with doing that, and so they will work you through this process. I'm not going to require you to know this, but just know that there is a calculation out there for that. Most sites will, that's the purpose of doing the visual of those tubes of 1, 2, and 3, and hopefully 3, it will have, that red blood cells would have diminished by then. So most sites, if they do notice that it's bloody and they compare to tube 1 and it's lighter than tube 1, or it has the appearance that there's less red blood cells, then they would just make a comment that results could be inaccurate due to possible traumatic tap, something like that. So your site should have some sort of canned comment that they will use to put in there for situations like this. Semen analysis is performed in order to determine male fertility, and we do this by checking the sperm concentration per millimeter as well as the sperm count for ejaculate. Fresh samples must be collected, and then they are allowed to liquefy within 1 hour of collection in order to get an accurate count. Once your specimen has liquefied, then you will do a ×20 dilution with your diluting fluid, and then you will use your hematometer. Now on your hematometer, you're going to look at that large center square, and within that large center square, you're going to count the 4 outside corners and then the square that's in the center of that. So you're actually counting a smaller area, and you're going to do this on both sides of the chamber. And then, of course, those results need to match within 10%. And then a factor of 1 million can be used if you use this method in order to do this calculation. Again, you have to have those particular squares counted as well as the ×20 dilution. So here we have an example that a dilution was performed with a ×20 dilution. The 5 smaller squares within that center square were counted, so you had the corners in the center. And then the average between the two sides was 72, so we're just going to assume they were within 10% since they gave us the average here. And then of course you'll plug that into what our factor of a million, so 72 times a million, and gives us 72 million. Of course you can simplify those numbers as well. Now to calculate the sperm count per ejaculate, you first got to get that actual sperm count, and then you have to actually know your volume of your specimen. So when you get your specimen, you're going to record your volume as well as things like the color of it. And there's a couple other things that you'll do, but we'll learn more about that once we get into our body fluids lectures. So for this particular example, sperm count was done with the times 20 dilution, 72. So we've already done this part of the calculation. However, the part that we have not, the information we have not been given up until now, is that there were 3 mLs of fluid. So you would have your sperm count times your volume. So that's 7.2 times 10 to the 7 times 3 mLs, and then that gives us a total of 2.16 times 10 to the 8th sperm per ejaculate. Reticulocytes. These are your immature red blood cells that can't quite be distinguished from your mature red blood cells on a right stain. Usually on a right stain, they're going to have a little bit of polychromasia type look to them, so they're going to have a little bit of a purplish hue to them. And so what a reticulocyte is it actually still has a little bit of those RNA remnants left in there where that nucleus has been spit out of that cell. And so you still have some of those remnants left. So it's kind of that stage in between losing that nucleus and being a mature red blood cell. And so we can only see these when we're doing using some sort of supravital stain to actually stain those RNA remnants. So a reticulocyte count is actually a percentage of those particular cells per 1,000 mature red blood cells. Now to do that retic count, you're going to mix equal parts of stain with equal parts of blood. You're going to allow it to sit and absorb that stain. Then you're going to push and make a slide, look at it on oil immersion, count 1,000 cells, and then out of those 1,000 cells, you're going to note each time one of those cells is an actual retic. Once you get those values, you'll plug that into your equation. So the number of retics counted per 1,000 erythrocytes times 100, and then you divide that number by 1,000, and it's going to give you a percentage. So for this particular example, we have 38 retics that were counted per 1,000 cells. Plug that into our equation, which is going to give us a reticulocyte count of 3.8%. Now some laboratories will just push the slide and do count those 1,000 cells, whereas some labs may actually use a Miller disc. And so this is where you actually take out one of the eyepiece oculars on your microscope and replace it with a disc, and then it just has this little grid that's actually on the eyepiece. So you're looking through that eyepiece and you're counting based off of what falls into each of those little squares. So you'll just kind of look at random fields in which red blood cells are evenly distributed, and you're going to look for the reticulocytes that are both within the large square and within that small square, and then you're going to count until the number of red blood cells in the small square reaches at least 200. So once we get those values, we'll plug it into the equation. So we need to know the number of retics that were counted in square 1 and 2, and then we're going to multiply that number by 100, and then we're going to divide that by the number of red blood cells in square 2 times 9. Now, why 9? Well, that's because that small square is 1 out of 9 parts of the whole. So when you look back at that previous slide, you can tell that it's kind of 1/9 of that total large square. So for this particular example, retic was performed using the Miller disc. 35 retics were counted along with 240 red blood cells. So this was a total of 35 within squares 1 and 2. So the overall large square. And then if you plug that in, you got 35 times 100, and then you divide that by 240, your total red blood cells times 9. And then when you work that out, that gives you a count of 1.6. The bone marrow produces red blood cells to replace the red blood cells that are actually in circulation that are damaged, and it replaces on about 1% per day. So this is reflected by the normal reticulocyte count of about 5 to 1%, or 0.5 to 1%. And so that's what the replacement rate is going to be in an average day. But in cases of anemia, the total number of mature red blood cells is usually decreased. And so this decrease is going to be reflected in the hematocrit, so you're going to see that lower hematocrit count. So because the reticulocyte count is based on the assumption that red blood cell count is normal, then you can actually get falsely elevated reticulocyte counts when you have cases of anemia. So sometimes we may need to do a correction for this. So in order to do this, what we'll need to do is actually take the patient's hematocrit and divide that by 45. So 45 is about the average of a normal hematocrit. And then, of course, the patient's reticulocyte count is then multiplied by that particular index, and that's going to correct for that lower hematocrit. So here we have an example where the patient's hematocrit is 30% with a reticulocyte count of 6%. So first we need to divide that patient's hematocrit by 45, so 30 divided by 45 times our reticulocyte count of 6%, which once we work that out will give us a corrected reticulocyte count of 4%. So when a patient has anemia, then the bone marrow is trying to compensate by releasing a lot of those young reticulocytes pretty early. So it's kind of forcing those out, which is going to create a shift in reticulocytes. And so the bone marrow is shifted because it's kind of pushing those immature red blood cells out quicker. And so what we're going to see is when we're doing our peripheral blood smear, you're going to see that polychromasia, that bluish, purplish tinge to those red blood cells, because you can tell they're immature. And they're usually going to be a little bit larger too, because as those cells start to mature, then they're going to start coming down and condensing to a normal size. So not only do you have to kind of keep in mind that the patient has anemia, you might have to do corrections for that. You also got to keep in mind that that shift is going to actually cause the reticulocyte count to need to be corrected because of that shift, because what's in circulation, those retics are going to be in circulation a little bit longer than what those other more mature retics are going to be. And so because of this, the reticulocyte production index will need to be calculated. And so this is a good indicator of how effective that red blood cell production is. And this formula kind of combines the reticulocyte index calculation with the factor for maturation. Now, a lot of your analyzers will actually give this to you now, so that's a good thing. You don't have to worry about this calculation. It's in your report. It's part of your data. Now, like I said, your analyzers are going to do this for you now, so you're not really going to have to memorize any of this. It's not a calculation that I've ever done working the bench, so don't worry about trying to memorize this and get this right. Just understand the concept and theory behind it of how this works with the reticulocyte count and the reticulocyte index and that mature factor in order to get this calculation that you will see on your printout. However, if you had to do this, this particular scenario, patient had a reticulocyte count of 6% with a hematocrit of 25. Shift reticulocytes were found when the cell differential was performed, so in other words, there was a lot of polychromasia going on. And then you calculate the RPI for this particular patient. So plugging all of those in, doing all those various little steps within there, you got the 6% times the 25% hematocrit divided by the normal, and then the maturation time, and that's based off the hematocrit. Just plug that in, and then once you plug that in, it gives you an RPI of 1.7%. So the red blood cell production index gives a clear indication of the patient's true reticulocyte count of 1.7%, and it is corrected for the patient's low hematocrit and increased production of reticulocytes. So once you actually start working in the lab, be sure to take a look at your printouts, look for this value so that you can kind of gauge what this value means and kind of start putting a visual with it. Osmotic fragility it's not really a test that's performed anymore. There may be some few specialty labs that still do this. However, this is kind of still listed as a potential registry question, so we will cover it. So with this particular test, it's going to usually be used for patients that have hereditary spherocytosis. So they have a lot of those abnormal spherical, full of hemoglobin red blood cells. This abnormal shape leads to an increased red blood cell destruction by the spleen, which is going to result in a chronic anemia. So it's going to cause some issues for the patient. So if this particular test needs to be done to kind of give you an indication of how this patient's red cells are doing, what it's basically looking for is the amount of hemolysis. And we're going to quantitate that hemolysis because when you have spherocytes, they will exhibit an increased fragility compared to what a normal red blood cell would. So this particular test is going to kind of give you an indication that you might have more of those red cells. Now, as far as how it's done, it's a matter of mixing it in the hypotonic saline solution, letting it sit, reading its spectrophotometer, and then going on from there. So what we're looking for is the percent of hemolysis that's going to be calculated in each tube, and then that's going to be based off the absorbance. You don't really have to know this, just know that this is basically a test that's going to detect the spherocyte hemolysis versus the normal red blood cell, because those spherocytes are they're going to hemolyze a lot faster, and then your normal red blood cells will. So one of the last calculations that we're going to talk about is going to be calculating an INR, International Normalized Ratio. And so what we do with this is, because the prothrombin time is one of the most commonly performed tests for patients who are actually on anticoagulant therapy, so this might be something like warfarin. And so what this test does is it uses thromboplastin from human sources as a reagent. So each of these lots of thromboplastin can actually have some variations to it, just basically because you're in different parts of the world, different parts of one state versus different parts of the country. So your actual donor source to make these reagents have some variation to them, because based off of patient populations, we're all different. So what this actually does is it kind of puts a standardization to actually being able to interpret whether you go overseas or whether you're in a different state. Then it actually kind of brings all of those values to a number, which doesn't really matter where you go or what reagent you're tested with. You still, whatever physician you're seeing can kind of base your particular situation and how your therapy with that particular anticoagulant is working for you, based off of you and not off of the variations in the reagents. So to do this, you'll actually take that patient's PT value and you'll divide it by the laboratory's mean PT value. So this is the international standard index that will be supplied to you. And so, for example, for this particular patient, their PT is 25.2, and so that ISI for that particular thromboplastin reagent used is the value for that is given to that laboratory is 1.287. And so when you plug that in, it's actually going to give you an INR of 2.4. So the physician might look at the 25.2 and say, okay, well that's high, but when they do it in comparison to that particular reagent, then 2.4 is actually therapeutic, and that's where they want that patient to be. So really when you do PT testing, the physician's going to be looking for that INR on that report. Your analyzers are basically all going to do it now. I don't know that there are many labs left that actually still has to calculate this, because it is going to be put into the analyzer or into your LIS system to do this calculation for you. The main thing that you've got to remember is that when you get a new lot of reagents, you're going to have to make sure you verify what that ISI is and make sure that you put that in the proper place when you're adding that new reagent. If you do not, and there's a big variation, you could be causing a lot of complications for your patients as well as your physicians who are trying to treat these patients.